Hey there, everyone, and welcome to today's lecture on anxiety disorders, diagnostic approaches, and clinical insights. Anxiety disorders are some of the most common mental health challenges we see, yet they often go misunderstood or misdiagnosed. My goal today is to help you feel more confident in identifying these disorders, understanding what makes them unique, and recognizing how they show up in the people that you'll work with. So let's start with a working definition. Anxiety disorders involve excessive fear or worry that's out of proportion to the situation and interferes with daily life. Fear is more about an immediate reaction to danger, so think fight or flight, while anxiety tends to be about anticipating a future threat. Both are part of the body's natural response to stress, but when this response becomes constantly triggered by things that aren't actually dangerous, it can cross into a disorder territory. So let's talk some numbers. Research shows that anxiety disorders are incredibly common, affecting nearly 30% of people at some point in their lives. Globally, the World Health Organization estimates that about 3.6% of people have an anxiety disorder in any given year, but this rate varies by country. In the United States, the prevalence tends to be higher, partly due to increased awareness, cultural factors, and reporting practices. What's interesting is that even though anxiety disorders are so prevalent, many people go undiagnosed or misdiagnosed, which can delay treatment and worsen outcomes. This is why diagnosis is so important. In psychopathology, we rely on tools like the DSM-5-TR and the ICD-11 to provide clear criteria. But diagnosis isn't just about checking boxes. It's about understanding how the disorder impacts somebody's life, considering cultural and developmental factors, and ruling out other possibilities. Anxiety symptoms can overlap with other conditions, especially obsessive compulsive disorder, which is also in the module this week. So part of our work today is learning to differentiate between the two. Misdiagnosing OCD as an anxiety disorder or vice versa is surprisingly common and can lead to treatment that doesn't quite fit. So here's what we're going to cover today. We're going to dive into the diagnostic criteria for anxiety disorders as outlined in the DSM-5-TR, and we'll touch on differences in the ICD-11. We'll break down the clinical features of key disorders like generalized anxiety disorder, panic disorder, and social anxiety disorder. We'll explore how to distinguish anxiety disorders from OCD, focusing on the unique role of obsessions and compulsions in OCD. And remember, there's a separate lecture for OCD this week, so you want to be sure to check in with that one also. Finally, we'll look at treatment approaches, from cognitive behavioral therapy to creative interventions like expressive arts and mindfulness techniques. By the end of this lecture, I hope that you'll feel more confident in diagnosing anxiety disorders, spotting the nuances in their presentations, and choosing interventions that fit the person in front of you. So are you ready? Let's get started. So to really understand anxiety disorders, it is crucial to get familiar with how they're defined and categorized in the main diagnostic manuals. The DSM-5-TR and the ICD-11 is the ones that we're working from today. Each provides a structured way to identify these disorders, but there are subtle differences between the two that can influence how we approach diagnosis. So let's start with the DSM-5-TR, which is probably the tool that most of you are going to use regularly. The DSM organizes anxiety disorders into distinct categories, and each has specific criteria. So let's do a quick overview of the key ones. We've got generalized anxiety disorder, and this is what we think of as worry about everything. The hallmark here is excessive anxiety about a variety of topics: work, school, finances. The list goes on, and that's going to last for at least 6 months. It's often accompanied by symptoms like restlessness, fatigue, muscle tension, or sleep disturbances. Think of generalized anxiety disorder as a constant hum of worry that the person just can't turn off. And then for panic disorder, people with this disorder experience sudden, unexpected surges of fear, what we call panic attacks. These are intense episodes where physical symptoms like racing heart, sweating, or shortness of breath peak within minutes. The key is that the attacks aren't tied to a specific trigger and are followed by persistent fear or another attack or changes in behavior to avoid one. Agoraphobia is the fear of situations where escape might feel difficult, like crowded spaces or open spaces. This can lead to avoidance of situations like public transport or even leaving home altogether. It's not just about fear, it's about intense avoidance of behaviors that interfere with daily life. And then we have specific phobia. The simplest way to describe this is a strong, irrational fear of a specific object or situation. So it might be spiders, heights, flying, you name it. The key here is that the fear is out of proportion to the actual danger and causes significant distress or impairment. And social anxiety isn't just about being shy. It's a pervasive fear of social or performance situations where somebody might be judged or humiliated. This fear has to be present in peer relationships, not just with authority figures, especially in kids. So each of these disorders requires a minimum duration of symptoms, often 6 months, and evidence that the anxiety causes clinically significant distress or impairment in functioning. It's also important to rule out any other medical or mental health conditions that might explain the symptoms. So that was the DSM-5-TR. I'm going to just talk about the ICD-11. So while it does overlap with the DSM in many ways, there are some differences worth noting. The ICD-11 takes a slightly broader dimensional approach. So for example, anxiety disorders are grouped with OCD and stress-related disorders under a single category, emphasizing their shared features. And the ICD-11 explicitly includes cultural and contextual factors in diagnosis, encouraging clinicians to think about how symptoms might present differently across cultures. One major difference is how the ICD-11 addresses mixed anxiety and depressive disorder. The DSM-5-TR treats this as more of a set of comorbid conditions, while the ICD-11 has a separate category for it altogether. And this matters in cases where anxiety and depressive symptoms overlap, but don't quite meet the full criteria for either disorder. So let's talk about culture for a minute, because this can't be ignored in anxiety disorders. Anxiety doesn't look the same everywhere. For example, in some cultures, anxiety may be expressed more through physical symptoms like dizziness or stomach pain rather than verbalizing fear or worry. The DSM-5-TR does include a section on cultural concepts of distress, but the ICD-11 goes further, requiring clinicians to consider cultural norms when assessing what's out of proportion. So there's a condition in Japan, I'm not even going to attempt to say this because I know I'm just going to get it wrong, but it's on the slide. And it talks about fear isn't just about being judged, but about embarrassing others. So this might resemble social anxiety disorder, but has this unique cultural implication. So if you don't know about this, this could easily misdiagnose or overlook the client's specific experience. And the key takeaway is this: anxiety is universal, but the way that it shows up isn't. As clinicians, it's our job to understand how culture, context, and individual experiences shape the expression of these disorders. So that's our foundation. We've covered the diagnostic tools that you're going to use, how they compare, and why cultural context is essential. Next, we're going to start diving into the specific disorders and their clinical features. So, anxiety disorders have this unique presentation, but they share common threads like excessive fear and avoidance behaviors. Understanding the clinical features, subtypes, and differential diagnoses helps us identify these disorders and offer targeted treatment. So, let's explore the key subtypes and dive into what makes them distinct. Generalized anxiety disorder is sometimes described as worry gone wild. People with generalized anxiety disorder experience excessive anxiety about multiple areas of their life. So, work, relationships, health, finances. If you can think of it, there's probably some worry surrounding it. And that's going to persist for at least 6 months. And it's not just worrying, it's feeling restless, fatigued, keyed up, often accompanied by muscle tension, irritability, difficulty concentrating, and sleep disturbances. So, an example might be Maria, 34-year-old teacher who spends hours replaying conversations with parents, wondering if she said something wrong. She's exhausted, wakes up several times a night, and has a constant knot in her stomach. Maria's worries aren't tied to a specific trigger, they shift from one topic to another, making them more difficult for her to control. So, some differential diagnoses that we want to take into consideration when thinking about generalized anxiety disorder. It could be major depressive disorder. So, in generalized anxiety disorder, anxiety is the primary symptom, whereas in major depressive disorder, worry is typically secondary to pervasive sadness or anhedonia. They travel together often. Generally, people who are anxious are also depressed, and generally, people who are depressed are also anxious. So, it's really important to figure out what's the primary and what's the secondary to make the correct diagnosis. We also want to look at obsessive compulsive disorder as a differential here. Generalized anxiety disorder worries are free floating in general, while OCD obsessions are intrusive, specific, and accompanied by compulsive behaviors to reduce distress. There's also physical health conditions like thyroid dysfunction and cardiac issues that can mimic generalized anxiety disorder symptoms and should always be ruled out. Treatments targeting these cognitive patterns like attention bias modification show promise in reducing symptoms, and we'll talk about that in a little bit. So there's some emerging research here. So new findings suggest that attentional bias towards threat and difficulty disengaging from negative stimuli play a role in generalized anxiety disorder. Treatments targeting those cognitive patterns like attention bias modification show promise in reducing symptoms. So next up, we're going to talk about panic disorder and agoraphobia together. Panic disorder is characterized by recurrent, unexpected panic attacks, intense episodes of fear that peak within minutes. Physical symptoms like chest pain, dizziness, and shortness of breath dominate, often leading people to believe that they're having a heart attack. Agoraphobia often develops alongside a panic disorder as individuals begin to avoid situations where escape might be difficult or if they have another attack. So, an example here might be something like James, a 26-year-old graduate student, had his first panic attack during a class presentation. Since then, he's avoided public speaking and even taking public transportation, fearing another attack. He now spends most of his time at home, limiting his activities to safe zones. So, panic disorder without agoraphobia, that's a unique presentation, even though there's some overlapping features. So, in that, panic attacks can occur, but avoidance behaviors don't develop to a clinically significant level. And then we can also have agoraphobia without panic disorder. So that would be avoidance behaviors developed due to fear of becoming trapped or helpless rather than fear of panic attacks. Some differential diagnoses to keep in mind here. We want to rule out cardiac issues. Symptoms of panic attack overlap significantly with cardiac events, so always rule out medical conditions first, and that might just be recommending that your client go to the ER to get checked out in the event that they're having a panic attack and we don't know what it is yet. We also want to rule out a specific phobia. So in agoraphobia, fear isn't tied to a single object or situation, but extends to multiple settings. For specific phobias, it's in the name, it's a specific phobia. And we're going to talk about that a little bit next. There's some emerging research here. So recent studies suggest that panic disorder may involve an overactive insula and amygdala, contributing to heightened interoceptive sensitivity or awareness of internal body sensations. Interoceptive exposure, repeatedly inducing and desensitizing these sensations, is a growing treatment focus. Social anxiety disorder goes beyond shyness. It's an intense fear of being judged or humiliated in social performance situations. Symptoms include avoidance of social interactions, heightened self consciousness, and physical signs like blushing or trembling. Shyness is a personality trait and doesn't usually interfere with functioning. Social anxiety disorder causes significant distress and avoidance behaviors that impair social, academic, or occupational life. An example here might be Ryan, a 19-year-old college freshman, skips classes that involve group discussions and avoids the dining hall because he's terrified of being judged while eating. His grades are slipping, he feels isolated, but the thought of asking for help is overwhelming. And looking at some cultural considerations here, like I was talking about before, social anxiety disorder can look different depending on cultural norms. We might want to ask any client with a Japanese background if their fear involves offending others rather than the fear of personal embarrassment. In some emerging research, we're going to talk about all of this a little bit later too, but there's been some advances in virtual reality exposure therapy that show promise for social anxiety disorder and some of these other anxiety disorders too. It allows clients to practice social interactions in a controlled, immersive environment, reducing avoidance and building confidence. And moving on to specific phobias. So these involve an intense, irrational fear of a specific object or situation like spiders, heights, or flying. These fears lead to immediate anxiety and is generally avoided at all costs, even if the object isn't actively present. So an example here would be Elena, a 45-year-old nurse, has debilitating fear of snakes. She refuses to hike, camp, or even visit her sister's rural home because she's terrified of encountering one, even though she knows the likelihood is low and she's never seen one at her sister's house before. It's just possible. So, specific phobias are categorized based on the type of trigger. So, animal type. So, think of dogs, spiders, snakes. There's natural environment type. So, heights, storms, water, lightning. Think of any sort of thing in the natural environment that might be a little scary. There's a specific phobia for it. Then there's situational types like flying, driving, elevators. And then the last type is blood injection injury type. So that's fear of needles or blood, often associated with vasovagal fainting. Differential diagnoses we want to look at is a social anxiety disorder. So fear in social anxiety disorder centers on social judgment, while phobias involve specific objects or situations. We also want to look at PTSD too. Phobias can develop after trauma, but PTSD involves a broader set of re-experiencing avoidance and hyperarousal symptoms. So, some innovative techniques like augmented reality exposure therapy are helping individuals confront phobic stimuli in safe, controlled ways. Additionally, research is exploring how early life trauma influences the development of specific phobias through heightened amygdala activity. So, understanding the clinical features of anxiety disorders and how they differ is foundational to accurate diagnosis and treatment. These distinctions might seem subtle, but they're critical for developing treatment plans that address each client's unique experience. Next, we're going to dive a little deeper into the role of OCD and its differentiation from anxiety disorders. So OCD is defined by the presence of obsessions, intrusive, unwanted thoughts, images, or urges, and or compulsions. So those are repetitive behaviors or mental acts performed to reduce distress. While anxiety may also involve intrusive thoughts, these are typically tied to general worries or fears rather than specific repetitive obsessions. Avoidance in anxiety disorders is more about reducing exposure to feared stimuli, whereas compulsions in OCD are ritualized behaviors performed to neutralize obsessions. So both involve excessive fear and distress. Avoidance behaviors in anxiety can sometimes resemble the repetitive actions seen in OCD, though the underlying motivations differ. So a person with social anxiety avoids giving a presentation because they fear being judged. A person with OCD might avoid presentations because they fear contaminating the microphone and ritualize cleaning before and after speaking. So again, there's another separate lecture for OCD completely, but just talking very quickly about the DSM-5-TR criteria for OCD, we've got obsessions, persistent thoughts, urges, or images that are unwanted and cause significant distress. The individual attempts to ignore or suppress them. And we've got compulsions. Those are the repetitive behaviors like hand washing or mental acts like counting, aimed at preventing or reducing anxiety. These are excessive and not connected in a realistic way to the feared outcome. Symptoms might be time consuming, taking maybe more than an hour a day, or cause significant distress or impairment in functioning. So I've got two case examples here to maybe help make this a little clearer. We've got Jenna, a 30-year-old teacher, checks her stove repeatedly before leaving the house, fearing that she might cause a fire. This ritual takes over an hour daily and causes her to be late for work. Her behavior might initially look like generalized anxiety about safety, but her intrusive obsession about the stove and compulsive checking point to OCD. Then we've got Michael, a college student who avoids public speaking because he's terrified of saying something embarrassing. While this avoidance might seem rigid, his fear is rooted in judgment, indicating social anxiety disorder rather than OCD. I think we got it here? So the line between OCD and anxiety disorders can be subtle but critical. Look at the thought patterns. Is it obsessions or is it worry? And behavioral responses. Is it compulsions or is it avoidance? OCD often involves a loop where obsessions fuel compulsions, which temporarily relieve anxiety but reinforce the cycle. Anxiety disorders lack this ritualized feedback loop. So let's do just a little bit more of a bigger case study here. So I don't know if you've ever seen Perks of Being a Wallflower, but you're missing out on a beautifully crafted story about adolescence, trauma, and healing if you haven't seen it. It's heartfelt, it's relatable, it's packed with incredible performances, and the film just navigates the sensitive topics like mental health, friendship, and resilience, making it a must watch for anybody interested in the emotional experience of what it's like to grow up. So Charlie is an introverted high school freshman navigating the transition to a new school while coping with the trauma of losing his best friend to suicide. Throughout the film, Charlie avoids social interactions, experiences significant anxieties about how others perceive him, and struggles to express himself. He often overthinks potential social situations and exhibits heightened self consciousness, particularly around his new friends and love interest, Sam. So, what do you think you might diagnose Charlie with just from this information, or if you've seen it? What does it look like to you? For me, it seems like social anxiety disorder. So, he's got this marked fear of social situations. Charlie frequently avoids social interactions or endures them with intense fear of being judged, embarrassed, or rejected. His fears interfere with making friends and participating in typical school activities. And during social situations, he appears tense, struggles to maintain eye contact, and becomes visibly uncomfortable. His symptoms persist throughout the film and appear to have existed for some time prior. So, why social anxiety disorder? The hallmark of Charlie's anxiety is his fear of social judgment, which aligns closely with social anxiety disorder. While he wants to connect with others, his anxiety about being judged or saying the wrong thing often holds him back. And we want to look at some differentials here. So, why not generalized anxiety disorder? That's going to involve broader worry across multiple areas of life. Charlie's anxiety appears to be specific to social contexts and not generalized. We also want to check in about avoidant personality disorder. So, that one involves a pervasive pattern of avoidance across relationships and situations, often rooted in a deep sense of inadequacy. Charlie demonstrates moments of social connection, bravery, and adaptability, which don't align with the diagnosis of avoidant personality disorder. We also really want to consider post traumatic stress disorder, noting that history about his friend. So while Charlie has experienced trauma, his social anxiety is not primarily tied to re experiencing or avoidance of trauma related stimuli. However, PTSD could be a co occurring diagnosis based on additional symptoms revealed later in the story. So, to confirm social anxiety disorder, what might you need to know or what questions would you ask Charlie? So, I would be concerned about the duration and onset of his symptoms. Did his behaviors emerge following a specific event, or has he sort of felt this way for a long period of time? So, again, we're looking for 6 months or more. And we want to know the degree of impairment in his daily life. Does his anxiety impact his grades, his family relationships, or future aspirations? And we also want to look for co occurring conditions, especially depression or trauma related symptoms, which are hinted at throughout in the movie. So, let's talk about some evidence based interventions here. Intervening effectively in anxiety disorders relies on evidence based strategies that target underlying mechanisms of fear and worry. So let's dive into three key components of treatment: cognitive behavioral therapy, medication management, and psychoeducation. Cognitive behavioral therapy is widely regarded as one of the most effective treatments for anxiety disorders. And I'm just going to say, I think that the research is a little bit biased because it's probably one of the most researched treatments for anxiety disorders because it can be manualized and it's really easy to study. It works by helping clients modify patterns of thought and behavior that maintain their anxiety. So some things you might have heard of. There's exposure therapy, and that's part of cognitive behavioral therapy. Exposure therapy systematically helps clients face their fears instead of avoiding them. So a client with a specific phobia like fear of flying might start by looking at pictures of airplanes, then progress to visiting an airport, and eventually take a short flight. Gradual exposure over time allows the client to habituate to the feared stimulus and reduce anxiety over time. For cognitive restructuring, anxiety disorders often involve distorted thinking, such as catastrophizing or overestimating danger. Cognitive restructuring teaches clients to identify these thought patterns and replace them with a more balanced perspective. So, for example, a client with social anxiety disorder might believe if I say something wrong, everyone will think I'm stupid. Cognitive restructuring could help them consider alternative thoughts like, people are probably more focused on themselves than me, and nobody's going to remember this 5 minutes from now. And then we would also look at relaxation and grounding techniques. So, techniques like diaphragmatic breathing, progressive muscle relaxation, and mindfulness can help reduce physiological arousal. So, a client with panic disorder might learn deep breathing exercises to use during an impending panic attack, reducing the intensity and duration of the episode. As far as medication management goes, so while CBT and therapy is generally the first line treatment for anxiety disorders, medication can play a critical role in managing anxiety, particularly for moderate to severe cases when therapy alone isn't effective. Remember, medications aren't this sort of like magic pill that just makes everything go away. They're meant to help calm the nervous system so that we can use the tools in therapy. So, some common medications that you might come across in treating anxiety disorders are those selective serotonin uptake inhibitors that we talked about in the depressive disorders lecture. So, examples of this are like Zoloft or Lexapro, and they're often the first choice due to their efficacy and tolerability. We've also got serotonin norepinephrine reuptake inhibitors. So, that's like Fexor or Cymbalta. We've got some beta blockers, and this one's really fun to think about. And they're generally used situationally for social anxiety. So, propranolol for performance anxiety. I've also seen things like antihistamines like Benadryl or Vistarol. And the way these work is basically they kind of trick the nervous system into not reacting with an anxiety response. So if your body's not reacting with anxiety, then your brain doesn't think you're anxious. And the last one that we can talk about here is benzodiazepines. So that might be something like Valium, Xanax. And these are rarely used now due to risks of dependency, but they can be prescribed for short term severe acute anxiety episodes. So, research suggests that combining CBT with medication can be more effective than either approach alone, particularly for clients with severe anxiety. However, it's essential to weigh the benefits against potential side effects and address client preferences. And last up, we've got psychoeducation. So, educating clients about anxiety disorders is crucial for reducing stigma, normalizing symptoms, and empowering them to engage in treatment. Clients benefit from understanding the fight or flight response and how it manifests in their body, how avoidance behaviors maintain anxiety, and why exposure can help, and the rationale behind treatment techniques like how repeated exposure reduces fear through habituation. It's not uncommon for clients to feel hesitant or skeptical about treatment, especially exposure therapy. To address this, you might want to use motivational interviewing to explore their fears and their goals, provide evidence of treatment efficacy, and start with very small, achievable steps to build confidence and trust in the process. And again, if you're not trained in exposure therapy, don't start it, don't do it. You need to get trained first. You can do a lot of harm exposing people to things before they're ready and not having the building blocks in place to get them ready to practice exposure. And of course, I want to make sure that I'm talking about some emerging therapies for anxiety disorder. So, not all of these are quite ready to go or approved or have a ton of research backing them yet. Some of them have a little bit more than others, but they're really interesting in the way that they're working. So, starting with virtual reality exposure therapy, it's really revolutionizing exposure therapy by offering a controlled, immersive environment to face fears without leaving the therapist's office. So, that example before about fear of flying, you wouldn't actually have to go to the airport. You would just put an airport on the VR headset, and it can create a sense of safety because, on one end, the client knows that they're not actually there, but it can help build that building block up to actually going to the airport. So, how it works is the clients would use VR headsets to stimulate these anxiety provoking situations, such as public speaking, flying, or crowded spaces. And VR allows for the precise control over stimuli, greater accessibility, and an opportunity for clients to practice their skills in a safe setting, right? They can just pull the headset off if it gets to be too much before inducing a panic attack. And studies are suggesting that this virtual reality exposure therapy is as effective as traditional exposure therapy for specific phobias and social anxiety disorder. It may increase engagement in therapy altogether. And there's this attention bias modification that I also talked about a little bit earlier, and it targets the cognitive processes that are thought to maintain anxiety, such as hypervigilance to threat. So, how it works is clients complete computerized tasks designed to retrain their focus away from threatening stimuli. For instance, they might repeatedly identify neutral faces in a series of threatening and non threatening images. Early research shows that attention bias modification can reduce symptoms in generalized anxiety disorder and social anxiety disorder, but the results are mixed. Ongoing studies aim to refine the approach and identify who benefits most. We've got acceptance and commitment therapy, where ACT emphasizes accepting anxiety rather than trying to control it, while focusing on living a values driven life. Clients learn mindfulness techniques to increase awareness and reduce avoidance, They also clarify personal values and commit to actions that align with those values, even when anxiety is present. ACT is gaining recognition as an effective alternative to CBT, particularly for clients who struggle with cognitive restructuring or prefer a more experiential approach. We've got MDMA assisted psychotherapy. So, while still in experimental stages and not FDA approved, right, you can't be doing this with your clients. MDMA assisted therapy is being explored for anxiety disorders, particularly social anxiety and treatment resistant cases. So, under controlled conditions, it's used to reduce fear and enhance emotional connection during therapy. Preliminary trials show promise, but more research is needed before it becomes widely available. We've got art based and somatic therapies. So, art therapy and somatic approaches like body scanning or movement based interventions are gaining traction as adjuncts to traditional therapy. Art based techniques can help clients externalize and process anxiety, while somatic therapies target the physical manifestations of anxiety through body awareness and relaxation techniques. And these therapies are especially useful for clients who struggle with verbal expression or have trauma related anxiety. And the rise of mental health apps and online platforms is making anxiety treatment more accessible. The last slide in this, I'm going to have a whole bunch of resources that you can look at even more. But there's apps like Wobot and Mindshift that offer CBT tools for self monitoring, psychoeducation, and guided exercises. And while these aren't a replacement for therapy, studies show that they can reduce mild to moderate anxiety symptoms when combined with professional care. Emerging therapies are expanding our toolbox for treating anxiety disorders, while traditional methods like CBT remain the gold standard. These innovations provide additional options that can be tailored to individual needs and preferences. For students entering the field, staying informed about these advances ensures that they offer clients the most up to date and effective care. So, emerging therapies are expanding our toolbox. So, let's break down neurobiological and psychological perspectives into simple ideas to make it really easy to follow. I really love brain stuff, but there's so much going on there. It sometimes is hard for me to keep everything straight and remember it. So, let's just talk a bit about anxiety really fast. Anxiety isn't just in your head. It's like a team effort between your brain, your body, and how you think and react to the world around you. So, what I'm going to describe next is how it all connects. So, the neurobiological underpinnings, what's happening in the brain. The brain and the body are like an alarm system. People with anxiety, people with anxiety, the system is a little too sensitive and goes off too easily. So, think of the amygdala like the alarm bell. Its job is to spot danger. In anxiety disorders, this alarm is too loud. It rings even when there's no real danger, making you feel scared or on edge. And then we've got the HPA axis or the stress factory. So the HPA axis is like a factory inside your body that makes stress chemicals whenever your brain thinks you're in danger. It starts with the tiny boss in your brain called the hypothalamus, which sends a signal to the pituitary gland, or think of it like the factory manager. And the pituitary then tells the adrenal glands or the workers to start pumping cortisol or the stress hormone that makes your body prepare for fight or flight. In people with anxiety, this factory never really slows down. It keeps churning out cortisol even when there's no real danger, making it hard to relax. Over time, this can make the brain even more sensitive to stress, like a smoke alarm that goes off every time you toast bread. And then, as far as neurotransmitters go, those are the brain messengers. So, your brain uses these tiny messengers to keep things balanced. So, for anxiety, we're focusing on serotonin, GABA, and norepinephrine. So, not really dopamine, even though it's on the slide. But serotonin is the feel good messenger. It's often too low, making it hard to feel calm. And then there's GABA, that's the chill out messenger. So, it might not be doing its job. So, you stay keyed up. And then norepinephrine, the adrenaline messenger, is sometimes too high, keeping you on edge. So let's look at how the way you think and act can keep anxiety going. This is where cognitive distortions come into play. So that's when your thoughts trick you. Imagine wearing funhouse glasses that make everything look scarier than it really is. People with anxiety can have distorted thoughts like, this is going to go horribly wrong, like catastrophizing, or everyone's judging me, like mind reading. These thoughts trick your brain into staying anxious even when the situation isn't dangerous. And then there's learning theory. Fear is a fast learner. Your brain is good at learning what to avoid to stay safe, but sometimes it learns a little too much too quickly. So if you feel scared while giving a speech, your brain might decide public speaking equals danger, and next time you're going to avoid it to stay safe. And then, as we're talking about avoidance, there's this anxiety loop. Avoiding things that makes you feel anxious feels better in the short term, but makes anxiety worse over time because we're rewarding it. So avoidance is teaching your brain, see, I was right, that thing is scary. We should be afraid of it. We should stay away from it. So the fear sticks around and even grows. So understanding the neurobiological and psychological sides of anxiety help us figure out the best ways to treat it. Therapy like CBT works on the thinking and avoidance habits, while medications target those overactive brain systems. Together, they help reset the alarm system so that you can feel calmer and more in control. And anxiety and trauma are closely connected, and it's common for symptoms of anxiety disorders and trauma related disorders like PTSD to overlap. However, understanding their intersection and differences is critical for accurate diagnosis and effective treatment. So, trauma often acts as a spark for anxiety disorders. Experiencing or witnessing traumatic events like accidents, violence, or natural disasters can leave lasting imprints on the brain and body. These imprints can manifest as both anxiety disorders and trauma related conditions. Trauma triggers the brain's alarm system, amygdala and HPA axis, keeping it stuck in high alert mode even when the danger has passed. This can lead to disorders like generalized anxiety disorder or panic disorder, where the person remains hypervigilant and unable to relax. While anxiety disorders often center on future worries or generalized fears, PTSD is directly tied to a past trauma. So, if we're differentiating between the two, are we looking at past or are we looking at future? PTSD symptoms revolve around re experiencing the trauma, flashbacks, nightmares, avoiding reminders of the event, and heightened arousal, like a startle response. Both anxiety disorders and PTSD can involve hypervigilance, sleep disturbances, and difficulty concentrating. This overlap makes it really easy to confuse the two, especially when trauma history isn't fully explored. Although anxiety disorders and trauma related disorders share symptoms, their root causes and patterns differ. So here's how to tease them apart. We want to look at fear. For anxiety disorders, fear is often generalized or future oriented, like worrying about health, safety, or social judgment. Trauma reactions in PTSD, fear is the specific trauma. A veteran with PTSD might avoid crowded places because they remind him of a battlefield, while somebody with social anxiety avoids crowds due to fear of judgment. We also want to look at re experiencing versus worry. So for anxiety disorders, worry is a what if cycle. For example, somebody with generalized anxiety disorder might think, what if I can't pay my bills? For PTSD, re experiencing involves intrusive memories or flashbacks of the traumatic event in the past, whereas the person feels that it's happening again. We're going to look at avoidance behaviors. So, in anxiety disorders, avoidance typically revolves around reducing discomfort in broad areas like public speaking or flying. PTSD avoidance is tied specifically to trauma triggers like avoiding certain places, people, or things or activities that remind that person of that past event. And then, as far as physiological arousal goes, both anxiety disorders and PTSD involve heightened arousal, but in PTSD, the arousal is often exaggerated and linked to specific trauma related triggers. And looking at the timeline and onset, for anxiety disorders, symptoms may emerge gradually and persist over time without a clear starting point. For PTSD, symptoms typically begin within 3 months of the trauma, though delayed onset is possible, and they're directly linked to the traumatic event. So, some implications for treatment that we want to think about. We want to address the trauma history. Trauma informed care is essential for clients presenting with anxiety symptoms. Always assess for trauma history to avoid misdiagnosis. Trauma focused therapies like EMDR or trauma focused CBT can reduce PTSD specific symptoms, while CBT is effective for generalized anxiety disorder too. Misdiagnosing PTSD as an anxiety disorder can lead to incomplete treatment, as trauma specific interventions might be overlooked. So, understanding the relationship between trauma and anxiety helps us to create a more accurate picture of what the client is experiencing. It also ensures that they receive the right interventions, whether that's anxiety focused strategies or trauma focused therapy or both. Wrapping up today's lecture, let's take a moment to reflect on the key points that we've covered and why they matter in your practice as future counselors. When diagnosing and treating anxiety disorders, it's essential to uphold ethical standards to ensure client safety and well being. Clinicians must be cautious of overpathologizing normal stress responses, especially in culturally diverse populations where expressions of distress may differ. Equally important is recognizing and addressing comorbid conditions like depression, PTSD, or substance use that can often complicate the clinical picture. Comprehensive assessment, cultural humility, and adherence to evidence based practices are key to providing accurate diagnoses and avoiding harm. So, we explored anxiety disorders and how they manifest, from generalized anxiety disorder to social anxiety disorder and specific phobias. Each has unique features, but shares common elements like excessive fear, avoidance behaviors, and significant distress. Accurate diagnosis requires more than just checking boxes. It involves understanding the client's experience, considering cultural and developmental factors, and ruling out other conditions like trauma or OCD. Evidence-based treatments like CBT, exposure therapy, and medication management can significantly improve symptoms. We also discussed emerging therapies like virtual reality, exposure therapy, and acceptance and commitment therapy as promising tools for the future. Anxiety doesn't exist in isolation. It's influenced by neurobiology, psychology, and social context. By considering all these factors, we can provide more holistic care. And getting the diagnosis right isn't just about being correct. It's about helping clients in the most effective way possible. Misdiagnosis can delay appropriate treatment, leaving clients stuck in a cycle of distress. So, treating somebody with PTSD as if they have generalized anxiety disorder might help their generalized worry, but miss the core trauma issues. Focusing only on medication without addressing avoidance behaviors and social anxiety can leave a client reliant on short term fixes rather than long term solutions. Individualized treatment matters just as much. No two clients experience anxiety the same way, so your approach must adapt to their needs, strengths, and preferences. A therapy plan that considers their values, cultural background, and life circumstances will always be the most effective. So before we wrap up today, I'm going to leave space for your thoughts and your questions. So feel free to comment below if you have questions or the answers to these questions, and I'll reach out with more detailed answers if needed. But I want to know what stood out to you today. Are there areas that you feel more confident in diagnosing and treating? And what challenges do you anticipate when working with clients with anxiety disorders? So, here are some resources that counselors can explore for more information on anxiety disorders, ranging from scholarly references to popular materials. And I want to just pull your attention towards this first grouping of resources. It's a lot of books, um, it's some articles, it's some research journals. Towards the end, it's more of the fun stuff like podcasts, TED Talks. I think they're all really, really wonderful. Rewire Your Anxious Brain is a lovely book. And it's a really great one that you can give to clients to read too. It's not just for professionals. I think it explains what's going on in the brain in a really manageable way that clients can really benefit from it. I love that TED Talk towards the bottom. Kelly McGonigal, How to Make Stress Your Friend. I could watch that all the time. I think that there's some really interesting science going on right there. And then the next section is apps. So Mindshift, CBT, WISA, Calm, Headspace, Wobot. These are all really cool apps. And then I just always love giving clients some group support. So some real life people that they can connect with. So Smart recovery groups are for clients dealing with anxiety in combination with substance use. Smart offers tools and worksheets grounded in CBT principles. Then there's Rise Up, Recover. Originally created for eating disorders, it's an app, but it's helpful for managing anxiety in group settings with tools like mood tracking and journaling prompts. So you can download that one and see what it's like. But remember, your role as a counselor isn't just to diagnose, but to walk alongside clients as they navigate challenges. Anxiety can feel overwhelming, but with the right tools and compassionate approach, you have the power to really make a difference in your clients' lives. You've got the knowledge, the skills, and the heart, so it's just putting it into practice. So thanks for watching today's lecture. I'm here for any lingering questions or thoughts if you want to explore, and let's continue this important work together. You got this.